So I want to take an opportunity to thank Mansoor and the rest of the planning committee for giving an opportunity to share some of the work that has been funded by the Ted Rogers Center for Heart Research. And this I'm going to use as a prototype for how you can take something from development to implementation. And this, I think, a big part of this is played by our translation and commercialization committee of the center that guides a lot of the projects as to how to move things to translation. I do have a couple of disclosures, which is that I'm a consultant for Bristol Myers Squibb and Tenaya Therapeutics. So I'll start with an example of a patient that we took care of at Sick Kids. The day began like any other school day as a boy prepared for school. It changed his family forever. At recess, he was playing basketball with friends. Suddenly, he collapsed, and his heart had stopped and could not be resuscitated. He was only 10 years old. 4 years earlier, he had been diagnosed with hypertrophic cardiomyopathy, which is a disease of the heart muscle that is associated with this complication, but there was no good way to know that he would suffer this catastrophic event. We know that hypertrophic cardiomyopathy, or HCM, is the leading cause of sudden death in children and young adults, and the #1 killer of student athletes. What you see in the line graph there is results from our multi-center registry, which shows that the risk of suffering a life-threatening arrhythmic event in children is almost 10% within 5 years of their diagnosis. And so the problem is the following. The extent of the problem is that there are 1 in 2,000 children affected with HCM. 1 in 10 children with HCM will experience life-threatening arrhythmias within 5 years of diagnosis. Yet only a quarter of the patients who are at high risk for these events receive a primary prevention ICD, which is a defibrillator that can shock them out of a bad rhythm and prevent death. And at the same time, 80% of patients who receive these preventive ICDs don't actually need them because they don't experience a sudden death event, and they are exposed to unnecessary complications related to the procedure. And the reason why we don't get this right as physicians is because the assessment of sudden death risk is still quite subjective. There are many risk factors that are involved, and it's very hard for the human brain to compute the individual risk based on multiple risk factors. So we lack robust prediction tools that are both objective, that are quantitative and individualized for the patient rather than just a subjective risk of high or low, and that are available to the physician at the ready, at their fingertips to use as point-of-care tools. So to solve this problem, and to find a solution, we established an international multi-center registry called Precision Medicine for Cardiomyopathy, or PRIMaCY, which involves 21 sites across Canada, the US, and Australia. And so far, we've captured over 2,000 patients with the children with this condition in the registry. We analyzed the first 570 or odd patients who were phenotype positive to try and find the risk predictors in children for sudden death, and we found that many of these differed from adults. A prior history of non-sustained ventricular tachycardia and a prior history of unexplained fainting increases the risk by 2 to 7-fold in children, similar to what it does in adults. But being genotype positive was also a risk factor, increasing the risk by 30%. In addition, there were several what we would call linear risk factors or continuous risk factors, like increasing age. As the age increases above 10 years, the risk increases. As the thickness of the septal wall increases or the left ventricle free wall increases, the risk of sudden death increases, not as a dichotomous more than 30 millimeters, less than 30 millimeters, but really as a linear risk factor. Increase in the left atrial diameter Z-score, that's the right graph, again shows a linear relationship with sudden cardiac death. But what was interesting is that having an increase in the peak LV outflow tract gradient was not associated with increased SCD risk. And in fact, as the gradient went to more than 100, like a very high gradients, it was actually kind of protective against sudden cardiac death, and we are evaluating why that is the case. Family history of sudden cardiac death, again, known risk factor in adults, did not come out significant in children, but we think that's just an artifact of age because the family members may not be old enough yet to have experienced that event. Also, we were not able to look at MRI findings in this analysis because that's only done in patients above a certain age. Nonetheless, we took these 8 risk factors and developed a model that involved some machine learning in order to be able to predict who might be at risk for sudden death. And what you see on the left in green are patients who have a 5-year risk of over 10% of sudden death compared to the remaining patients. And when we looked in the middle graph, as you can see, when we looked at the predicted 5-year sudden death risk to the observed, it had a pretty good C statistic or a concordance statistic of 0.75 for the clinical-only model, 0.76 for the genotype included model. But what was important is this was the first tool that we actually validated using an external registry called the SHARE registry, which is another international registry, where we were able to show that we maintained the performance of the calculator to more than 0.7, which is considered quite reasonable for such a risk calculator. We published these results in 2022 in Circulation, and the same year it was adopted as part of the evidence base for the AHA-ACC practice guidelines for hypertrophic cardiomyopathy, advocating for the use of more individualized tools for predicting sudden death risk, and for using that information to guide shared decision-making with families about whether or not they would want to get an ICD or to prevent this death from happening. So, I mean, this is usually often where we tend to stop, but this is when our knowledge translation has occurred. But we know that the Ted Rogers Center for Heart Research, an important goal is to translate the research so that it reaches the clinic, and this is directly from the website. And one of the ways to reach the clinic is to develop precise, predictive digital health solutions that can be used at the individual patient level. So we took that to heart and decided we need to move this directly into the hands of the physicians in a more convenient way. So the first thing we did was launch a web application that is shown here, PRIMaCyCalculator.com, where the physician, it's an external calculator, but any physician anywhere in the world can input the variables from their own patient, and you can see what it looks like, and it gives the 5-year risk of sudden death events. In this case, for example, this is a 14-year-old boy whose 5-year risk for sudden death came out to be 6.8%, so it's a modest risk. If the same patient had had a history of unexplained syncope, that 5-year risk would have gone up to 62%, a 10-fold increase in risk. So this is more powerful when you're discussing with families what the risk is, as opposed to saying, we think your child is at high risk, because now they can take that information, balance it with the risks of the procedure itself to decide whether or not they want a preventive procedure done for this. We did post-marketing surveillance, which is where we looked at what is the uptake of this tool as a web application. Within a few months, we were able to show from back-end usage of the tool that there were over 450 users from across 41 countries. Majority of them were from North America. And we did a survey of the users in North America and found that 100% of users found the tool to be clinically useful in practice. 52%, however, used it always, but 37% only used it sometimes, and 11% never used it. What was important was 88% said that we would use the tool regularly if it was integrated into electronic health records. So we did a market survey or a pulse for the market to see how many centers in North America have electronic health records, and 100% of pediatric hospitals who have cardiomyopathy services have interoperable electronic health records. Of these, 75% use Epic, which is the electronic health record at SickKids and now also at UHN. If we were to capture that market, we would capture almost over 200 physician users in North America who see collectively over 13,000 pediatric HCM patients. So we approached the Ted Rogers Translation and Commercialization Committee, who you can see the leaders of that committee who are really, I would encourage everyone who's doing any kind of research with Ted Rogers to really meet with them, because they give you ideas not just for a startup company or commercialization. Not everything needs to be monetized, but there are ways to improve the impact of what you're doing through other means of translation. So they advocated for funding, which was approved by the Ted Rogers Center, just for the initial seed funding to convert our web application into a prototype to be integrated into Epic. So this work is already launched, which we hope to complete early in next year. We leveraged this seed funding of $50K to get a CIHR project grant that will allow us to integrate the tool not only into Epic at SickKids, but also at all other pediatric centers in Canada over the next 3 years. We made sure we had the right team expertise. So in addition to clinical cardiologists, we included a digital health expert from University of Toronto, Emily Cito, and an implementation scientist from SickKids, Melanie Barwick. And this is important because users tend to forget that there is a tool at hand. So you have to implement it in a way that is sustainable and will show continuous use for it to be effective. So the whole CIHR project is to make sure the implementation is done in a way that is sustainable. We made sure we had key partners from SickKids, which are the Chief Information Officer, the industry partners like Epic and MD Calc, and patient partners in this endeavor. And what's most important is, from a patient perspective, in order to help with shared decision-making, it's easy to say the physician can give a percentage risk, but the patients need to have the educational background to understand and balance the risks based on their own tolerance of risk. So we are now working with Robin Haimes from SickKids, who is a health service researcher, to integrate shared decision-making tools into the same workflow as we have for the physicians. So I just want to close by saying, so the value proposition that we posed to the Ted Rogers Center, which is what helped us to get the funding, was that 1 in 10 children with HCM are at risk for sudden death or near-death event. Currently, we put in 9 ICDs to prevent 1 death, and still we don't prevent all the deaths. With our tool, even with 70% accuracy, if it was used sustainably, we would put in 4 ICDs in order to prevent 1 death. This would result in 33% fewer ICDs, 63% fewer deaths, and 47% predicted lower costs, healthcare costs related to both SCD and ICD use. So I'm going to stop there. I was just going to show that this is just a very small example of where digital health technology is headed. This just shows it's growing into a multi-billion-dollar industry, and digital, health is the way this is often going to play out. So I just want to thank the app development team, which includes Steve Fan, the biostatistician, Tanya Pappas, who was our program manager, very instrumental in doing the survey for the market use, and Sarah Lee from Epic at SickKids, and all the investigators who are part of our PRIMaCY network, and of course, Ted Rogers Center and the other funders of our work. Thank you very much.